Hello, and welcome to Critical Content from Critical Care Medicine. I'm your editor-in-chief, Dr. John Sevransky. Today, I am very pleased to introduce my two guests. We have Russ Roberts, who is the clinical pharmacy manager for cardiology, critical care, and pediatrics at Mass General Hospital, and he also has faculty appointments at Tufts University and Northwestern University School of Pharmacy. Did I get that correct?
Northeastern University School of Pharmacy.
Northeastern University. My apologies. You are in the Northeast. And I'm also fortunate to have somebody from my own institution, Tu-Trinh Tran, who is the clinical pharmacy specialist for the medical ICU that I work in, and also she's the residency program director. So welcome to Critical Content. Today's conversation is inspired by the article An IV Sodium Bicarbonate Shortage in the Critically Ill, an Interrupted Time Series Analysis by Dr. Leong and colleagues. And Dr. Leong is a pharmacist. And you can find the article online at ccmjournal.org. It is found in the November issue of the journal. So I'd like to first start out with Dr. Roberts. Can you tell me how do drug shortages, such as the previous sodium bicarbonate shortage in the critically ill, impact your workflow?
That's a kind of a loaded question. I think it impacts our workflow greatly, especially now, before drug shortages were just happenstance type things that would happen, and then we would pivot. Now, because they're so routine, much like the major bicarb shortage that happened in 2017, there's been heparin ones, et cetera. Now it's actually part of our daily workflow. So we pretty much embed it into our workflow to be able to pivot the right way. That wasn't always the case. But it does take a lot of person power to basically look at how a shortage is evolving and then put in all the steps that are going to take place. So there's essentially six big buckets that we go through at our institution when we think about a drug shortage. And the first is it starts with situational awareness and operational control, which is really the fancy way of saying the behind the scenes stuff that pharmacists are doing to look at what is going to be the impact and will actually impact the front line. And do we have to, mobilize the troops, or can we get by? And a lot of these elements, a number of things go into these things, such as this first one, we're looking at, all right, what is the manufacturer telling us? Is it going to be next week that they can supply it if it's a shortage right now? Is it 2 months from now? Is it the next calendar year? The distributor information. How much do we have on hand? Where are we using it? Before we get to the whole, is it appropriate or not? But like, where is it being used? Are we going to run out tomorrow? Are we going to run out a week from now? What you probably don't know, Dr. Sevransky, is most of the pharmacies now go by what's called a just-in-time inventory. So we don't keep tons of product on the shelves like they did in the past. We keep just enough to balance the cost ratio, because we rely on manufacturers are going to resupply it. So then we talk about all those things, what's on hand, how often we're going to track this. Are there escalation thresholds we can put in place at this time that we don't have to disrupt clinicians for? Meaning, like, can we reallocate product? Maybe one, we'll call it Omnicell dispensing cabinet has a ton in it and it's not really used, but maybe it needs to go to the ED. Again, we're trying to do a lot of things behind the scenes that don't affect the frontline provider and, of course, the patient, of course. Protect the areas like code cards. And we look at all those things of where usage. And then we think about formulations and routes. Are there actually alternatives that we have? Is it like, okay, the vial's on shortage, but a pre-filled syringe is not, for instance? And, what's our capacity to even compound, which not every pharmacy or institution has that ability. I'm lucky at MGH, we can compound quite a few things, but can we compound it from scratch? Is it hazardous, non-hazardous? So all those things are happening behind the scenes as we try and think about, okay, when do we have to escalate to the next phase, which is, okay, we think this is going to be a big enough problem that we really need to get our providers and subject matter experts to really look at what our usage and go, okay, we're going to be short. Are we going to have alternatives? And what is your clinical judgment to say, should we be treating this patient for this indication? So that goes into the second point, which is escalation in governments. And these like go sometimes simultaneously, these steps, or, they all intertwine. So in this step, we've already determined it's going to be a big enough issue. We've done all the things we can do behind the scenes to help out. Now we really need to get expert opinion and work as a team. And that's really what we are. But we don't want too big of a team. So we really have stakeholders in place already at MGH. So we have a whole drug shortage team. So we have the, division chief of ED, critical care, et cetera. So we have point stakeholders that step up when we have these questions to take back to their groups or to be the decision holders, because, we can't have too many cooks in the kitchen or it goes crazy, but we need the right people. So when we do that, we want one set of decisions instead of every unit, creating its own practice because of a shortage. And then out of that naturally dovetails into clinical prioritization. So we always think of like, okay, what are the must-have indications? So if you talk about the bicarb situation, where is bicarbonate, sodium bicarb really needed clinically that shows a patient will benefit versus what are the, okay, we use it, but we could probably get by without it. We have all those philosophical conversations, of course, evidence-based, and try and say, okay, lower value use might take a back burner. The goal is conversation that's intentional and not accidental. So we're all involved. And then once we come to those kind of decisions, and I'm paraphrasing, this takes a lot of person power, a lot of meetings, a lot of hours, as you can imagine, with staff that we don't really have to do and pivot, but we do it. Then we talk about workflow standardization. How is it going to affect the frontline staff and actual clinical outcomes, et cetera? Do we need to, how are we going to standardize it in our electronic health record? We have Epic here. So how does it affect Epic? How does it affect the pumps? How does it affect our guidelines and the guardrails we have, especially if it's a newer drug that might replace another drug? So optimizing all those things and providing embedded guidance if possible. And that's not feasible at every institution. So, we want clinicians to be able to do the right thing quickly, especially during busy shifts. So it takes a lot of systems to touch, and you really got to be nimble. And then once we get all of that in place, we're still left with, all right, how do you communicate this to all the clinicians at the bedside, which is a massive undertaking. Everything gets lost in email, et cetera. So, I like to say we over communicate, and I'm hoping it's always the same consistent message. That's what we try. So we have emails, we have a drug shortage website. We have focused education halls. I'll go to the MICU and talk with that group. Staff meetings, different division meetings, all within reason, right? Because sometimes these shortages happen quicker than not. Pharmacists are on rounds spreading information. So we try and really hit every group, from nursing, providers, respiratory therapists, everyone. And then the last step, if it wasn't complicated enough, there's implications for using alternative therapies that may not be as effective or create new risk. So safety surveillance is huge. Shortages don't just, reduce one medication, right? They often shift care patterns. So, part of my work becomes monitoring for unintended consequences, like, changes in vasopressor use or dialysis needs, electrolytes, bicarb, for example, ventilation adjustments. Does it affect how you're going to do stuff at the bedside, for example? And then updating those guidance and as new signals come along. If we find we're using something now, all of a sudden, all these patients are going hypotensive, then we got to figure out, okay, we got to pull back and figure out what's going on and talk with our subject matter experts again, the leaders at the bedside. So as you can see, those are like 6 very paraphrased steps, but each step is so complicated. And to give you an example, I work 40 hours a week, managing and also staffing in the ICUs, but we have 2 dedicated FTEs. So 2 people we pay salary just to manage drug shortages. Now, not everybody has that luxury, but it gives you the idea of just how invasive the problem is. Every day, there's probably 200 or 300 drug shortages behind the scenes that you as providers don't even know about. Some of you do because you're involved in it, but most bedside clinicians don't know. And we're behind the scenes just trying to mitigate those things so it never gets to you. The 10% that do are very difficult and challenges that we need your help and guidance on. So we're constantly calling manufacturers, figuring all these things out. So you can see that it's a lot of work. But that's typically how we do it. We have checklists. We have all those things to try and not forget. I oversee adults and pediatrics. So that's a big issue. Sometimes we forget about our pediatric friends. So I'm always like, let's not forget about them. How does it affect them? So it's very challenging, but we're getting better at it. And that's sad to say, just because there's so many shortages.
Okay. Thank you. It does sound complicated. Dr. Tran, what would you add to that?
Yeah, so I would just want to echo more on what Russ have spoke on. The biggest thing about drug shortages is collaborative approach. We really meet with all the stakeholders and really try to identify what are the key things that we have to focusing on, who are how long these shortages are going to last, what formulation is it going on shortage, and what can we do in the meantime to wait until the manufacturer give us notification that the medications are back. Especially this year, right? We have seen a lot of fluid shortages during, the hurricanes. And so that really have taught us a lot about how to reserve the fluid for the right patient and really coming to the group and really identify that important, the number one, I guess, prioritizing which patient really need it and really focusing on those patients. And a lot of people work together in the background to kind of help monitoring the supplies that we have and really try to communicate with the providers as much as we can so that we're all on the same page.
Okay, thank you. And my second question, and maybe Dr. Tran, I can hand this to you first, is how do you counsel a clinician when there's a drug shortage and you don't have a readily available substitute? What do you tell them?
Yeah, so this is a great question. It's something that we do every day, during round, trying to having that conversation, really try to identify the problem and the solution for the patients. So to me, when it come across, especially sodium bicarb, if we are having a shortage, we really try to identify which patient do we really need this for, right? Because a lot of time we want to treat the number and not the patient, and that's really not what we should be focusing on for patients' care. And so a lot of study for sodium bicarb have became available over the last few years. On top of the bicarb ICU-1 trial, we have the bicarb ICU-2 trial. And then with the study that you mentioned earlier, kind of focusing on the shortages, really all these studies kind of show to us that sodium bicarb doesn't really improve mortality outcome for the patients. And so we should focusing on, based on these trials, what kind of the key points that they have pointed out. And so really these studies have show associations between using sodium bicarb for severe metabolic acidosis patients, that primarily in patients with AKI. And so when you're using sodium bicarb in these patients, we can help stabilizing their hemodynamic. But really, the key point is that it avoided delaying in renal replacement therapy. And so we really have to look at the patients and really figuring out what is the underlying causes of the acidosis, and whether or not sodium bicarb is going to provide any benefits for these patients, and really figuring out, can we use tablets for these patients? Can we use, do we have syringes in-house? Do we have the vials? Because we have so many different formulations. And so I think that it's important to, again, like meeting with the stakeholder and really figuring out what are the primary patients that we need to focusing on, and really try to prioritizing those patients and focusing on those patients first, and try to have alert pop up. And obviously having a pharmacist in round is really useful because you have a human person who just in there and screaming and saying, no, you can't do that, or yes, you can do this. And so really figuring out, do they meet the criteria, and talk with the team and really figuring out, will this going to affect the outcome or not? What is this going to change for the patients? And kind of prioritizing that and treat the patients and not the number itself.
Thank you. Russ, what would you add to that?
I would say I agree with everything Trin said. I said one of the things I tell clinicians is when the substitute, for instance, isn't identical, and we're going to go down this path, is, don't think swap the drug, think replace the clinical goal. What's the physiologic endpoint we're trying to achieve, as Trin said, like is there certain patients we can get by not using it? What are we trying to do here? And what's the safest path? Ultimately, some patients will need, the equivalent of bicarb, for instance. So, we were lucky here at MGH where we had sodium acetate. So this was a big, educational moment for the providers as well, because now we're getting into another drug that they're not used to seeing, maybe in TPNs and stuff, but it's actually given differently. So you really need to assess the risk. So for instance, bicarb, right, we push it in 30 seconds half the time. Maybe we do an infusion, but when we're pushing it for acidosis, we push it really quick. You can't do that sodium acetate. You have to give it over 20 minutes, or you might have massive hypotension leading to cardiac instability. So, you're reflexively needing to change your practice sometimes when it's a new drug, and understand how does it affect your ventilation management if it's a certain other drug, et cetera. So we all work together, but I try and make sure if we have to use it, they understand the risk or the lack of risk if we just don't know as well. But to what Trin says, we basically definitely collaborate to go, who is the best patient to use it in, and who can we conserve it in for the right reasons based on the evidence as well.
Thank you. So I'd like to thank my guests, Dr. Roberts and Dr. Tran. If you want to read more about drug shortages, please look at an IV sodium bicarbonate shortage in the critically ill, an interrupted time series analysis by Liang and colleagues. And I'd like to thank the viewers for watching.